In this paper, in the American Journal of Psychiatry, we review and discuss the clinical issues related to the treatment of alcoholic patients in the context of liver transplant. Alcohol is a major risk factor for all liver disease, including alcoholic fatty liver disease, alcoholic hepatitis, and alcoholic cirrhosis. In addition, excessive alcohol use may worsen the course of liver disease due to other etiologies, such as hepatitis B and C, as well as non-alcoholic steatohepatitis. Liver transplant may represent a life-saving treatment for alcoholic patients with end-stage liver disease. Indeed, patients who are transplanted for alcoholic liver disease have survival rates comparable or even higher than those of patients with other etiologies for their liver disease. However, the probability of referral for alcohol etiology of end-stage liver disease remains significantly less compared to non-alcoholic etiology, regardless of current drinking status. One important reason for this low referral rate is the bias held against alcoholic patients as candidates for liver transplant. On a scientific and the clinical level, the hope and goal is to increase access to liver transplant for alcoholic patients with end-stage liver disease. And an equally important and complementary goal is to ensure that alcoholic patients with end-stage liver disease receiving transplant have a proper medical care for their alcohol problems.
Abstinence from alcohol is the most important therapeutic goal for patients with alcoholic liver disease. During acute detoxification from alcohol, some patients may require pharmacological treatment for alcohol withdrawal symptoms. In this case, shorter-acting benzodiazepines, such as lorazepam, temazepam, and oxazepam, having primary urinary excretion, are preferable in patients with reduced liver function. Abstinence from alcohol can improve liver function overall, and in the case of patients being evaluated for liver transplant, 6 months abstinence from alcohol is often required in order to be considered for placement on a wait list for liver transplant. Relapse to drinking alcohol often results in removal from the wait list with the requirement to start recovery and 6 months sobriety once again. Therefore, in these patients, it is crucial to optimize the chance of abstinence by providing both behavioral and pharmacological interventions that may help patients to achieve and maintain abstinence from alcohol. Of the 3 medications approved by the Food and Drug Administration to treat alcohol use disorder, acamprosate, disulfiram, and naltrexone, acamprosate, which undergoes minimal hepatic metabolism, has few mild side effects and no liver-related side effects. Thus, its use in alcoholic patients with end-stage liver disease is considered safe. Other promising medications that are FDA approved for other indications have been tested in phase 2 or 3 trials, and some of them are often used off-label for alcohol use disorder, including topiramate, ondansetron, baclofen, gabapentin, and varenicline. Most of these medications have no evidence of liver toxicity, although only baclofen has been formally tested for safety and efficacy in alcoholic patients with end-stage liver disease.
An example of how pharmacotherapies may be used in this population is discussed in the case vignette that opens our review in the American Journal of Psychiatry. This case illustrates a female alcoholic patient with end-stage liver disease that is seen in the emergency room and then hospitalized due to complaints of increasing fatigue, shortness of breath, and abdominal gift. On physical exam, she appears jaundiced with distended abdomen due to ascites and pedal edema. Laboratory and imaging exams confirm the diagnosis of alcohol-related end-stage liver disease. This psychiatric evaluation indicates a diagnosis of a current alcohol dependence. The patient also has a current diagnosis of nicotine dependence. The hepatologist and the psychiatrist further evaluated the patient for liver transplant together with other members of the liver transplant multidisciplinary team. In spite of not being abstinent for 6 months, the clinical team will eventually decide to include the patient on the waiting list for liver transplant. Notably, the patient agrees to start a combined treatment that includes a behavioral treatment with adjunct pharmacotherapy in order to maximize her chance of maintaining alcohol abstinence.
As illustrated in the case vignette, pharmacotherapy options are discussed. Disulfiram and naltrexone are excluded given their risk of liver toxicity. The hepatic toxic risk of ondansetron is uncertain, so this option is also excluded. Topiramate is ruled out as cognitive side effects might confound detection of hepatic encephalopathy, for which the patient is being treated prophylactically with lactulose. Acamprosate is avoided as it may worsen diarrhea associated with lactulose. The remaining 3 options, baclofen, gabapentin, and varenicline, are also discussed. As the patient is a smoker and is now willing to consider quitting, having learned of her new diagnosis of severe liver disease, varenicline is started. The patient will receive a liver transplant. We're talking today about a 48-year-old. She will receive an integrated program, both pre- and post-transplant, of behavioral therapy with motivational interviewing, as well as treatment with varenicline to help her maintain abstinence before and after transplant. This case illustrates how a multidisciplinary team approach with experts in addiction and psychiatry, as well as hepatology and transplant, can facilitate a successful transplant. This approach optimizes outcomes with alcohol use disorder in patients pre- and post-liver transplant.